I'm really honored to be here. I would like to thank very much the organizer of this meeting. I'm starting with my disclosures that you can see here. And with a very quick and rude comment about peripheral T-cell lymphoma that are clearly accounted as one of the most or the worst lymphomas among the subtypes that we know, and also one of the worst cancer in humans. There are several explanations for this reason. One of course, is the aggressiveness of the disease, but also knowledge is limited in these cases, mainly because they are rare diseases, 10 to 15% of non-Hodgkin lymphoma. They are very complex in terms of the clinical features, biological features, and about very few known risk factors. And this has also contributed to a slower development of clinical research in this setting, with few novel agents available in these lymphoma subtypes compared to other lymphomas of the B-cell phenotype. Among the most recent advances, I think that, as already mentioned in the previous talk, one of the biggest advances has been the review of the classification of the peripheral T-cell lymphomas according to a cell of origin concept, similar to what is being done in diffuse large B-cell lymphoma. And there are now several cell of origins that can lead to different peripheral T-cell lymphoma subtypes. The most frequent, as you already mentioned, are the T follicular helper peripheral T-cell lymphomas that include angioimmunoblastic T-cell lymphoma and other peripheral T-cell lymphoma in OS, accounting overall for 40%. I'm not going into the detail of this classification, but I think this is very important because not only it provides novel and accurate and reproducible criteria for the diagnosis of the lymphoma, but also it provides the target that should be considered when novel agents are being developed and are being used in these subtypes. I'm referring to the involvement of the epigenetic machinery in the T follicular helper subtypes of the P53 and STAT and MYC genes in the GATA3, the BED, PTCL and OS, and alteration and methylation in the PTCL and OS of the TX21 positive subtype, CD30 in anaplastic large cell lymphoma, just to give some example. Being diagnosed with peripheral T-cell lymphoma is bad news, but the news is even worse if the patient is relapsed from initial therapy. There are several reports describing very poor outcomes for patients with the peripheral T-cell lymphoma relapsed or refractory. As shown here, these are data derived from the prospective T-cell registry headed by Professor Massimo Federico as an international effort to include and enroll a significant number of peripheral T-cell lymphoma around the world. As you can see here, regardless of the disease being relapsed or refractory, the median survival is very short, 11 months for a relapse, 5 months for a refractory disease. And there is a certain relationship between the survival and the time of relapse, according to the concept of POD24, that, however, doesn't allow to distinguish between poor or good patient, because all patients with relapse are poor. They are worse if they relapse early, with a significantly worse survival compared to the patient who relapse later than 2 years. And according to the subtypes of the peripheral T-cell lymphoma, the relapse the outcome after relapse is worse overall, with a few exceptions represented by the ALK positive anaplastic large cell lymphoma, as shown in the right panel in this slide. And from the experience of the MD Anderson Cancer Center, what is already been concluded is that little improvement has been achieved with time in the management and the outcome of the relapsed patient with peripheral T-cell lymphoma. As shown here, as you can see, 381 patients included in this registry, subdivided by time of relapse, and no significant improvement in terms of failure-free survival or overall survival is observed in this comparison, confirming that very little improvement has been achieved in this setting. Moving to some of the recommendation about the treatment, I would like to show this slide summarizing the clinical practice recommendation about the treatment and the transplantation of mature T-cell lymphoma. There is currently being identified as the standard approach for the aggressive counterpart represented by B-cell lymphomas. There is overall an agreement that autologous stem cell transplant should not be considered as an option for relapsed refractory patients. This is mainly because for patients who are eligible to autologous transplant, this option is already considered in first diagnosis, so to consolidate CR1. I mainly agree with this recommendation, probably with the only exception of anaplastic large cell lymphoma cases with ALK positive, for whom I would not consider consolidation of first CR if the CR is good. And in these cases that do not receive autologous stem cell transplantation, if the disease relapses, I would strongly opt for autologous transplantation at time of relapse. There is moving to allogenic transplant, that for the time being is one of the most important option if you consider the cure as the aim of your treatment for a relapsed refractory patient. There is a weak recommendation in favor of prescribing and proceeding with allogenic stem cell transplant for almost all peripheral lymphoma subtypes. However, we know how difficult it is to move a patient with relapsed refractory disease to an allogenic transplant. There are no randomized evidence in, supporting this recommendation. Most of the data come from different retrospective series and few retrospective data that are shown here, confirming that with an allogenic approach, regardless of the conditioning regimen, it is possible to achieve overall survival rates that range from 30% to 70%. But it's very difficult to to draw a firm conclusion based on this retrospective data. There are larger analyses, again retrospective. This is one produced and published by the French colleague that put together 285 patients who received an allogenic transplant and tried to correlate the outcome of the patient who received the transplant according to the phase of the transplant. And what they were able to conclude is that transplant can be a good option associated with an overall survival that is around 70%. At 5 years, with some patients that can be cured with this option, but the option is best when used hopefully in first CR and is not associated with significant improvement of outcome and with poor results when used in patients with later relapse or without a good response to induction therapy before allogenic transplant. And at the ICML meeting that was held recently, the German group presented the results of a cooperation between US and Europe that put together a large series of patients that received allogenic transplant, and they looked at the source of the cells for the allogenic transplant, comparing haploidentical transplant with HLA sibling patient and with MAD patient. And what we're able to observe is that not only haploidentical transplant was associated with the reduced toxicity compared to the other transplant, but as shown in this slide, the outcome of the patient who received haploidentical transplant was very similar compared to the other allotransplant options, suggesting that if you have a patient with relapse and you are considering allogenic transplant, haploidentical approach could be a good choice. It's not very easy to assess the role of high-dose therapy in general in peripheral T-cell lymphomas, also including the first line, because there are several checkpoints that are not controlled if you're running a retrospective or a single-arm prospective study. This includes a potential difference in outcome observed for different peripheral T-cell subtypes, the different risk groups, what induction therapy you prescribe to the patient, how you assess the response before moving to the transplant, And in the case of autologous, if you're able to harvest the peripheral cell stem, or in case of allogenic, the type of donor that you're including. That all together makes it very complicated, lacking randomized data to assess the real role of high-dose therapy in peripheral T-cell lymphomas. So apart from peripheral T-cell lymphoma and from other chemotherapy option, the field of relapsed refractory peripheral T-cell lymphoma is perfectly suited for the development of novel agents. And looking at the new drugs that we are with data available in terms of clinical efficacy and activity, we can distinguish the agents from the new so-called new old drugs. There is activity for asparaginase, mainly in NK T-cell lymphomas. Bendamustine has shown some kind of activity, mainly in angioimmunoblastic T-cell lymphoma. There is a French study, the Bentley study, that is in favor of the use of this agent as single drug in relapsed refractory setting. Pralatrexate is an analog of methotrexate that has received an approval by FDA, but not in Europe, based on promising data achieved in the relapsed refractory setting. But for example, in my country, we are not able to use pralatrexate because of lacking of phase 3 evidence in favor of this agent. And the most interesting results come from the use of novel targeted therapies that can be subdivided among monoclonal antibodies. There are interesting data about alemtuzumab, Braintaximabetine, that I will provide more details in the later slides, and anti-CCR4 mogamulizumab. And there are huge amount of data about the use of epigenetic modifiers, including histone deacetylase agents or hypomethylating agents. There are currently 4 histone deacetylate agents, romidepsin, vorinostat, belinostat, and kedamide, that have been virally approved based on the good results achieved with the early clinical studies in the treatment of relapsed refractory peripheral T-cell lymphomas, but are not widely approved all over the world. They're mostly approved in the United States. In Europe, we do not have any one of these agents available for the management of the patients. And among other agents, there are tyrosine kinase inhibitors that can be used and are being tested in specific subtypes with discordant results. And there are also miscellaneous agents, including the IMiDs with lenalidomide, the PI3 kinase inhibitor that have some kind of activity, and other agents that I will be able to discuss in the subsequent slides. Starting from the monoclonal antibodies, of course, the first and the most interesting agent is Braintaximabetine. There is an antibody drug conjugate that targets CD30, and that has been tested mostly in Hodgkin lymphoma and in peripheral T-cell lymphoma, starting from the relapsed refractory setting. And I think that you all know, you will remember this waterfall plot describing the activity in terms of response obtained with single agent Braintaximabetine in patients with relapsed refractory anaplastic large cell lymphoma. There is the subtype with the higher expression of CD30. And I was really impressed when I first saw this data that reported an overall response rate of 88% and 81% in ALK negative and ALK positive, with 52% of the patient with ALK negative and 69% of the patient with ALK positive who were able to achieve a complete response with one single agent. And of course, you already learned about the subsequent development of this agent that is now available for the treatment of relapsed patient with a single agent, but is also approved in combination with CHP in the first-line therapy of anaplastic large cell lymphoma and other CD30 positive peripheral T-cell lymphomas. Regarding other lymphomas different from anaplastic large cell lymphoma, Braintaximabetine has been also tested. The first concept that should be emphasized here is that the activity is seen, but the problem here is that not only the expression of CD30 is highly variable in peripheral T-cell lymphoma NOS, but also that the response in the first phase 2 study presented by Steve Horowitz the activity of Braintaximabetine in that study was not predicted by the level of CD30 expression, as shown in the right panel in this slide, that describes responsive observers also in patients that were defined as CD30 negative. So I don't think that the CD30 anti-CD30 therapy with Braintaximabetine is the best option for all comers with peripheral T-cell lymphoma. I still consider expression of CD30 in the patient to decide about the treatment of this patient and the prescription of the Braintaximabetine. A different situation is observed in cutaneous T-cell lymphomas. We have a randomized study in this case that randomizes CD30 positive cutaneous T-cell lymphoma with relapsed refractory disease to receive Braintaximabetine, single agent experimental treatment, or a physician choice. And the results here were clearly positive in favor of a better efficacy of Braintaximabetine as measured in terms of peripheral progression-free survival, and also overall response rate was higher in patients that received Braintaximabetine, suggesting that in this case of CD30 positive lymphomas, Braintaximabetine is an option. As a general comment to this slide, however, I think that as observed also in Hodgkin lymphoma, Braintaximabetine alone can hardly be considered a curative option for the patient that in the case of cutaneous T-cell lymphoma tend to have a very quick response to the drug, but also tend to relapse very early, very soon when the drug is interrupted after 1 year of therapy. Moving to the other class of agents with the most promising data that are histone deacetylase inhibitors, romidepsin is the agent that has received most of the attention and with most of the most interesting data. This is a summary of the results of the phase 2 study of romidepsin, single agent used in peripheral T-cell lymphoma relapsed refractory cases. There was a certain degree and promising rate of responses observed here with 25% overall response rate and with 15% of complete responses observed and 11% of PR as shown in the table. In terms of site of tumor reduction, you see that approximately 2/3 up to 3 out of 4 of the patients experienced some reduction in the size of the disease, and the progression-free survival was also not good as one could expect, but probably better than what is observed in patients that do not receive any treatment or have other options compared to the previous slide that I showed in the beginning of my presentation. The promising results observed in a relapsed refractory setting prompted several investigators. This is a French study to try to compare the standard therapy with CHOP with the modified CHOP that was implemented with the romidepsin as experimental regimen. This is a first-line study, so not previously treated patient. And regardless of the promising data achieved with single agent, the study was not able to show the hypothesized superiority of the RO-CHOP combination. However, when you look at the results of the study by subgroup, even if you have not allowed to draw firm conclusion, I think one of the most interesting results is that there is probably a differential activity of romidepsin plus CHOP according to peripheral T-cell subtype, confirming what was initially observed in the different pathology classification according to the cell of origin that I showed in the first slide. In this case, only angioimmunoblastic cell lymphoma experienced some better results from the use of RO-CHOP compared to the CHOP that was not seen in other lymphoma subgroups, suggesting that probably romidepsin can be confirmed as a promising agent, but not for all comers, but mainly for the subtype that are more sensitive to this drug, and in particular to the T follicular helper peripheral T-cell lymphomas. And this observation, moving back to the relapsed refractory setting, is probably confirmed if you look at the different survival achieved from this series from the MD Anderson, from the Memorial Sloan Kettering group, that comparing the activity of romidepsin in peripheral T-cell lymphoma compared according to the cell of origin. As you can see here, there are not good results overall because the survival is bad, but there are relatively better results in terms of PFS and response observed for the T follicular helper subtypes with 4.1 months better than the 2.1 months for the other subtypes, suggesting again that there is strong suggestion that romidepsin may work differently in different peripheral T-cell lymphoma subtypes. Another epigenetic drug is azacitidine that we all know, very well know from other hematologic malignancies. There is a hypomethylating agent. There are small studies that show some activity of this agent when used as a single drug. 12 patients treated in this series. Overall response rate 75%, with 6 out of 12 patients, 50%, that were able to obtain a complete response, and with a survival that was considered very promising in this setting. One important question now that we have some agent with single agent activity is whether we are doing well, if this is the right way to go. And this is a question that was asked by the author of the complete registry, that is prospective US registry, that prospectively enrolled a huge amount of patients at time of diagnosis, but also at time of relapse. And in this report, the authors looked at the simple question, tried to answer a simple question, was whether any single agent among the new agent that I discussed before, used in a patient with peripheral T-cell lymphoma, was associated with better results in comparison with the old and conventional combination chemotherapy. And as you look at from this slide, the results of this survey were in favor of the better activity achieved with any of the single agent, including pralatrexate, Braintaximabetine, hypomethylating agent, or eastern deacetylase inhibitor, compared to conventional chemotherapy, with a suggested significant improvement in overall survival. This doesn't mean anything in terms of clinical recommendation, but it mainly tells us, in my opinion, that we are moving in the right direction. So the new agent really represents a promising option for the management of a very bad disease. And what we are now experiencing is a second generation of clinical trials in the relapsed refractory setting. They are basically moving from a single agent therapy to a combination therapy. And I show you some of them that are mostly based on a combination of romidepsin plus something. This is romidepsin plus pralatrexate, small study, 14 patients, but the combination of the therapy was associated with an overall response rate of 71%, and with 4 CR and 6 PR among the patients, suggesting good activity of the two compounds. Most interesting data, I think most promising data, come from the combination of the two epigenetic modifiers, the HDAC inhibitor romidepsin and the hypomethylating agent 5-azacitidine. This is a phase 1 study, 31 patients, among of which 11 were peripheral T-cell lymphomas, and you can see here 73% overall response rate, but 55% complete response rate, with a strong rationale that was also in the use of combination, also confirmed looking at the biology of the disease, with more patients responding to the combination among those with an enrichment in the mutation of the epigenetic machinery. This phase 1 study was followed by a phase 2 study that was recently published on Blood by Falke and co-workers. In this case, 23 patients, an overall response rate 54%, CR rate 38% overall. But among the T follicular helper peripheral T-cell lymphoma, there were 17 cases. The overall response rate was 80%, and a 60% rate of CR was observed, with PFS, with also treatment-naive patient with very interesting results of PFS for this subgroup of patients who were never treated with for a peripheral T-cell lymphoma. Other combination possible: PI3 kinase inhibitor, a single agent activity documented with romidepsin again. This is another study presented at the last ICML meeting by Stephen Horwitz. It was part of a more complex study that also included a combination of duvelisib and bortezomib. But for the time being, the data of duvelisib and romidepsin were presented, showing here responses in most of the group with an overall response rate of 58% and with a CR rate of 40%. And with the highest dose level of this phase 1 study, it was possible to observe a 55% complete response rate. That was really interesting and really promising to allow us to consider this combination in future trials. Another combination shown here is with the IMiD lenalidomide with romidepsin. In this case, also lenalidomide has shown activity in the relapsed refractory setting. And in this case, again, ICML, a phase 2 study for treatment-naive patient was presented with a combination of lenalidomide and romidepsin. The details of each cycle are shown here. Patients were treated for up to 1 year. And in terms of response, all evaluable patients were associated with 75% overall response rate, 30% complete response rate. And among angioimmunoblastic T-cell lymphoma that are now, I think, they could be considered as the most sensitive subtype to novel agent, 84.6% overall response rate and 38.5% complete response rate. Small studies, few patients, but I think that they are all in favor of suggesting that combination with novel agents should be considered in the future. And the same study, when they looked at the peripheral of the survival for all patients and for the angioimmunoblastic subtype, the PFS was quite interesting. Remember, this is a first-line therapy, so with a chemo-free option, without the need of using anthracycline or CHOP or more intensive chemotherapy, it was possible to achieve 2-year progression-free survival in 39.6% of the patient, at least for the angioimmunoblastic T-cell lymphoma, with a median PFS of 1.83 years. Of course, we need more patients, but again, this I think will be important for the future. Before concluding, I cannot conclude without saying anything about the possibility to engage the immune system in the treatment of peripheral T-cell lymphomas. As learned in B-cell lymphomas, this is a strategy that has provided and has allowed to achieve important results, mainly in the relapsed refractory setting, and can be achieved with the use of checkpoint inhibitors, B-specific antibodies, the targeting of tumor-associated macrophages, as for example, with CD47, anti-CD47 agents, but also with CAR-T. This slide regarding CAR-T in peripheral T-cell lymphomas, the development of CAR-T in this subset of lymphomas is conceptually difficult because if you use CAR-T to target a T-cell, if you transform a T-cell into a CAR, there is a high risk of fratricide killing of the therapy, and that can also result in determining a T-cell aplasia. Another problem for the development of the CAR-T is about the choice of the target for the CAR-T that has been considering with different options, addressing with CAR-T directed towards CD5 or CD7. There is, however, a strategy that is frequently associated with T-cell aplasia, and or with restricted antigens like CD30 and TRBC1. The most promising experience in this setting of CAR-T therapy in peripheral T-cell lymphoma is currently being conducted with CAR-NK cells without CAR-T. So CAR-NK cells directed towards the CD30 antigen, but we'll see in the future when the clinical data of the trials will be available. Few words about checkpoint inhibition in peripheral T-cell lymphoma. there is a different degree of expression of PD-1 in peripheral T-cell lymphomas. This is a phase 2 study of pembrolizumab single agent for the treatment of relapsed refractory T-cell lymphoma. There is some degree of activity. However, the all-comers peripheral T-cell lymphoma, in my opinion, are not the best candidate to receive a checkpoint inhibition strategy. Also because there is a stimulating activity of interaction between the anti-PD-1 agent and the T-cell that may result in hyperprogression, as documented in a few case reports from the literature, available from the literature. So again, there is probably a suggestion that checkpoint inhibition is not bad for all patients, but there is some patients who can benefit from the use of checkpoint inhibitor, and these cases are represented by the NK T-cell lymphomas that also, due to the strong and frequent expression and frequent involvement of ABV, are highly expressor of PD-1, PD-L1 axis, and there are some initial reports from the literature showing activity of checkpoint inhibitors, in this case pembrolizumab for the treatment of NK T-cell lymphoma relapsed refractory, with some promising and initial results that prompted several authors and several groups to define treatment strategies, including checkpoint inhibitors for the treatment of these cases. This is the ISG50 study. There is a small, but I think interesting study for peripheral T-cell, for NK T-cell lymphoma who are not eligible to chemotherapy, but who are treatment naive, that instead of receiving chemotherapy that they cannot tolerate, receive a combination strategy of involved site radiotherapy plus pembrolizumab for up to 2 years to maybe test the hypothesis that a chemo-free option for this patient at low risk but not eligible for chemotherapy can be good enough to achieve good control. In future, if these studies, like others, enrolling patients now, will confirm the activity of checkpoint inhibitors in peripheral T-cell lymphoma and NK, this could be a good option for the future development. This study is being conducted now in China. And in conclusion, bispecific antibodies, similar to what I already discussed regarding CAR T-cell therapy, several attempts to combine different epitopes in the antibody have been tried. The most interesting results are those achieved with the bispecific antibodies combining a CD30 activity with a CD16A that once again is directed towards the NK cell. And this is a phase 1b/2a study that is currently ongoing with 14 patients accrued and with an overall response rate observed of 40%. You see on the right at several dose level the responses that were observed with most of the patients who responded who achieved a PR with a few CR observed mainly at low doses. And I think this is a strategy that should be considered a promising strategy, but we will need more time, more patience, and in the future we will see if this is the right way to go also for peripheral T-cell lymphomas. So I would now rapidly go to the conclusion. I think that you all agree that treating relapsed refractory peripheral T-cell lymphoma is one of the biggest challenge for an hematology oncology doctor. It's very difficult. It's very difficult to manage a patient with so few available options. Current approach is not based on evidence at all, also including those recommendations we would consider as the stronger recommendation, starting from allogenic transplant in a relapsed patient. Nevertheless, if allogenic transplant is feasible for the patient, I think that this approach should be tried as soon as possible, moving for first relapse. And in this case, if a donor is not available, haploidentical allogeneic transplant is also fine. And as you could see, targeted therapies are expanding their role in peripheral T-cell lymphomas, with some general data that are more promising. Anti-CD30 patients should be treated with Braintaximabetine. I think that in this case, combination strategy would be associated with better activity. and probably being used more frequently to achieve those results that can now be used to target the patient, to bridge the patient to a more conclusive, complete option, like, for example, allogenic stem cell transplant. And the other class of drug, HTAC inhibitor and epigenetic modifiers overall, are representing the most important background of all the chemo-free combination that have been tested. And with this, I would like to thank you for your attention, and I'm ready to take questions.